So moved. Okay. Second by anybody?
I'll second.
Okay. All in favor?
Aye.
Citizens to address the board? I don't think we have anybody tonight. Approval of the consent agenda tonight, March 24th, 2014, board meeting minutes. Need a few minutes to go over a little bit.
There's a typo on page 4. Third item at the bottom about the Carl Gutierrez. Lehman stated that the medical staff meeting was held. Just a missing word.
Okay. Thank you.
Okay, with that change, if there's anyone that wants to move to approve the agenda, the consent agenda, I'll entertain a motion. Move.
Second.
Mr. Second, all in favor? Okay, we need to change the date of our May meeting due to the Memorial Day weekend. I'm not sure what's a good day. Jenny, you have any ideas over there?
Well, Tom comes up for Tom's meeting, so the next day, Tuesday, would be a good.
Okay, I'm okay with that, if everybody's okay with that.
It's the 27th. Everyone's good with the 27th?
June 27th?
And same day for finance? Goes on finance?
Yeah.
Fine, that's the same thing. If you have any problems or anything, just get a hold of me. Okay, Annie, Saturday, are you ready? Give us an update on the ICD-10 implementation.
My name is Annie Satterley. I'm the Director of Health Information Management. As most of you guys know, that's the Medical Records Department. So I'm just going to give you an update on the ICD-10. For those of you that don't know what it is, I will read this a short clip of what it is and then what we're doing and where we're going. So ICD-10 is the International Classification of Diseases. The 10 is the 10th revision. There's CM and PCS. The CM is your diagnosis coding, like congestive heart failure, hypertension, AFib is your diagnosis. PCS is your inpatient procedure coding. CM and PCS are compatible versions of the U.S. developed ICD-9 counterparts, which U.S. adopted in 1979. So you can see it's already 30 years old, and it's only made out of numbers, so we're actually running out of diagnosis codes for things that are going on when you're finding new diagnoses or using new technology for procedures. We can't expand on that anymore. So ICD-10 is going to help us with that. ICD-10 will give us more information per code. There's a lot of laterality, right versus left. We have initial versus subsequent encounters, and routine versus delayed healings for like your fractures. So it tells the insurance company and the other physicians taking care of you where you're at in the disease process. ICD-10 is going to give us better support for care management, quality measures, and analytics. It'll give us improved availability to understand the risks of severity. ICD-9 currently has 16,000 diagnosis codes. With ICD-10, we're actually going to have 68,000 with room to expand. Procedure codes in ICD-9, there's only 4,000. With ICD-10, we have 90,000 currently. When is it coming? Well, the expected date was October 1st of this year, but on April 1st, the President signed into law the Protecting Access to Medicare Act of 2014, which passed the House on March 27th, passed the Senate on March 31st. While its preliminary focus of the law is to provide temporary patch to the substantial growth rate for physician payments, Section 212 established a delay for the implementation of ICD-10. The language states that the Secretary of Health and Human Services may not adopt ICD-10 codes prior to October 1st of 2015. So right now at this moment, we don't have a date when we're actually going to be able to use ICD-10. So we're currently waiting for further direction from the Center of Medicare and Medicaid Services. A little bit about what Cibola Hospital has done. We have put together, over a year ago actually, an ICD-10 team which consists of clinical and non-clinical staff. Our non-clinical would be our PFS or Patient Financial Services, because they do still need to know what's going on and able to assist the coders to bill the bill correctly. We have a project plan. It was pulled together by QHR and AHIMA using all their resources. We review this project plan monthly at our monthly team meetings. And right now we're also having a monthly QHR webinar that reviews all new ICD-10 initiatives and any learning opportunities that we may have. Originally, we had come up with a comprehensive budget for coder training only of $11,000. Since then, though, with our meetings, we realized that we would have to increase that budget due to all the physicians in the community and the training that they would also need. This requires us to upgrade our 3M coding system and the virtualization for our off-site coders. Right now, IT says that our system will only hold the coders that are off-site that we currently have, which is 2, and a few people in the administrative group that can virtually network into their computers from home. So right now they're working on the IT hardware and integration and installation, which is at about $40,000. 3M is only part of that, and we hope to have the 3M part updated within the next 30 days. When I tried to dual code, we found out that HMS was not aware that anybody wanted to do that, and actually wasn't even ready for the phase. What dual coding is?
Tell them what HMS is.
HMS is our electronic medical record that we document in.
You got so many federal initials. Can you determine which one's which?
For dual coding in 3M, which is our coding system, I can code in ICD-9, and then I can switch a tab, toggle over to ICD-10. We were trying to do some end-to-end testing because we're far enough ahead with our coder training and some of our IT things that we were ready to get started. I mean, we want to get this done. And then when we had them turn it on, we found out that HMS was not ready to start that. So we actually had broken our system for a couple days until they wrote a program to fix it. And now we're hoping that HMS will take this next year and actually be ready to implement those stages. So in order to make the dual coding and end-to-end testing a reality, Rick from our IT department says there's another database that is like $300,000 that we would have to implement into our HMS system. That way we can code in it, we can run end-to-end testing, working with Patient Financial Services. They can actually follow the bill all the way to our payers, make sure that they'll get paid. Our coder training has been going on for over a year. I am actually an AHIMA certified ICD-10 trainer. Tally, who is a coder that works offsite in Alaska, has attended both of the online coding workshops for diagnosis coding and procedure coding. Sandra, who's one of our coders in California, has attended a 2-day workshop. And Dale Smith, who works on site here, just completed her coding certification, has had quite a bit of information and to do with ICD-10 coding, as well as Dale and I, Pat from the clinic, who's a certified coder, all are attending a monthly seminar in Albuquerque that's put in by the New Mexico Health Information Management Association. And Sunny from Dr. Valdivia's office also attends those with us. When the 3M system is fully upgraded, we'll be spending an additional $6,000 on a coding documentation training system, which will include training for the hospital physicians as well as the coders. We'll be able to actually make available to physicians maybe information in their specialty. For instance, Dr. Ocampo, who does pediatrics, we can assign her pediatric modules, and then she has to actually test in them, and we can follow those through to see how she's doing. And the same with the coders, we can assign them modules, and if they're an outpatient coder, or an inpatient coder, or a surgical coder, then be able to see where they need more help. So where do we go from here? Well, the hospital is going to continue to follow our project work plan every month. We'll probably take it out to every other month again, since there's been over a year delay, because we are, I think we're ahead of the game more than other hospitals, because we are actually ready to start testing, and nobody's ready for us. So we'll continue to work with all of our vendors, including HMS, to ensure that they are ready, they have complete readiness for ICD-10. And the coders will continue to work with our physicians via queries to ensure quality documentation and that their documentation supports the severity of illness. I've also given the physicians books that help them understand kind of the coders jargon versus physicians jargon, to try to help them understand where we're coming from. And our query process has helped a lot. I talked to Carl a lot. Not very much anymore. He's getting it.
Annie, can you give us an idea or the importance of the coding and what we're doing?
Right. Because you want to know exactly what the patient's being treated for, one of our things is congestive heart failure. There's multiple codes for congestive heart failure. You can have just unspecified, which is going to give you what we call a lower DRG. It doesn't show how severely ill the patient is. Whereas if they had acute or chronic congestive heart failure, either diastolic or systolic, or maybe just acute, that is actually going to show the insurance company how come we used so much stuff to cure this patient. It shows them how severely ill they were. Same with chronic renal failure. There are 5 different levels, and then you go to end stage, or just chronic renal failure unspecified. It doesn't tell you how sick the patient is unless we ask our physicians, can you please stage how sick this patient is? So it shows their severity of illness, and then why we're using everything we're using to help them get better. It also is a reflection on the physicians in their scorecards for insurance companies, because if anybody can pull up a physician and they can see how high their mortality rate is, but then they would be able to see how sick their patients were. So even though a physician may have a high mortality rate, that's because he's taking care of older, sicker patients. As long as he gives us that information, that'll be reflected. So that shows he is a very good physician.
I might add that this is really a massive project for this hospital, for this country. We're looking at going from 16,000 codes to 68 or 64,000, about 4 times as many codes.
Yeah, 90,000 for procedures and 68,000 just for diagnosis.
This hospital is going to be spending probably in excess of $500,000 to get there. She mentioned $300,000 IT. We've already spent a bunch of money on it for IT. We have more planned in the future, plus all the training that we're sending people to, and instructional books, et cetera, that we're buying. So it's going to be a good $500,000 ongoing for this hospital to make this change. And it's going to be a rough change for us and for all the hospitals, because the physicians have to really adjust to all this. It's going to be a huge adjustment for them too. And we can only do the coding side of it. Physicians have to write all the, or talk about all the stuff that they're doing in much more detail than they've ever been used to. So it's going to be very difficult for them and their business offices too to get all this information across so that the correct coding and the correct reimbursement can be obtained. So it's a big project for Seymour, for a small hospital and a big hospital.
Just another comment. I think we've talked about this before. The rest of the industrialized nations have been on ICD-10 for a long time. The United States is the last to adopt it. However, we're the only country that's tying it to reimbursement. So, despite the fact I feel really good about Civila's readiness, one of our biggest concerns is that with this year delay, hospitals would kind of put it on the back burner, which, as you've already heard, you guys are not. But even probably as big a concern is, no matter how ready the hospital might be, it doesn't mean the payers are going to be ready. So when the switchover happens in 2015, you may have all your ducks in a row, but if the insurance companies are not ready, then you don't get money in the door. So
And that's why we're trying to do the dual coding as soon as possible. Lucille in Patient Financial Services, has looked at some of our payers and is working with them already for us to try to get our bills through to them. So we thought about even actually dropping hard claims just to see if the codes would go through their system. So that's still a possibility. Yes, ma'am.
I think it's really a good point that all of this, when you hear, for the new people, when you hear all of the money that's going into everything, it's not because we want to, it's because the government basically is forcing us to have this system, that computerized system, the whole bit, the codes, it's all tied to reimbursement. So if you want to exist and get any reimbursement, then you have to follow all these rules. And it's not that we've chosen to spend this money, the government's forcing us to, because none of us would have done it.
I just practice first.
That's
You guys take care of the rest. That's the way it is.
Any other questions from anybody I can answer? Thank you very much for having me.
Thank you.
guys have a nice evening.
You did a good job.
Thank you.
Stay off the horse.
Okay, executive report.
Yeah.
We will say. CEO report.
Yes, I included in your packet, the report. The first one is growth, and we're looking at, physician recruitment. We heard from Dr. Siegel. I think I told you last month that we did an interview with him, but he was waiting on his sister-in-law, see if they got a white husband job in Albuquerque, and they didn't. So he's taking a job in Colorado. So you couldn't get State Farm or Farmer Mutual, whoever he was interviewing with at the time, come down and sort of. So that one's down. The next one is really Dr. Haley Wallace, and I separated them for some reason. I don't know why. And she's the one that's doing a residence that gets out in July of next year. And it's, Dr. Chip was there another middle today after the push rotation she's in, and trying to develop a time frame for us to interview her, bring her down and interview her. Also, we have a new position, recruitment committee, and we need to set a date for that committee to meet. Because we need to look at what we're going to be doing in the future, how we're going to be recruiting, and then also identifying, which areas are we going to be recruiting in. And so it's important for us, for the finance and the position recruitment committee to meet and provide us some directions on where we need to go. So if any of you got dates, Jenny will email you out some times and dates, and we'd like to have it the next 2 weeks if we can, next 2 to 3 weeks, and seeing if we can get some new activity going on in the physician recruiting side. Dr. Florentine has been in contact with us, and he'll be here on May 8th to start looking at houses. And so he's excited about coming. We're excited about him getting here. We're in the process of making sure all of his paperwork's done, J1 visas and state applications for license and all that stuff right now. So we're want to get him where he can up and going as fast as we possibly can. Next, under the pillar of people, that we're going to, in the process of putting together what we call a committee of high performers. High performers in our definition is employees who sees a problem, analyze the problem, coming up with solutions to the problem, and then correcting the problem. That's a real short type of definition. Medium employees sees a problem, analyze a problem, and goes to Maria, Glenn, or one of us, Dr. Carl, to see if they can solve that problem. And a low performer blames me, Carl, Glenn, everybody for the problem instead of analyzing. So what we're doing is trying to develop a committee of high performers that can help us identify areas or ways that we can retain those. High performers are the people you really want to build your organization on. We spend a lot of time trying to manage the low performers, and so we need to switch that around and spend more time trying to help the high performers meet their needs in the organization. And so we're going to be setting up a meeting in the next 2 weeks or so for them to sit down, and then I'm going to be with that committee, but I'm going to just be an advisor. I want the committee to come up with, how do we make this a better place to work for high performers? What do we really need to be doing now to meet your needs? And hopefully we'll come up in the next 2 or 3 months with some good structured ideas of how we can do performers. And I found out this is a best way to make change if you include the employees in the decision-making process. And they work hard on trying to come up with a solution. It's their solution instead of being mine or Jeff's or leader's solution. It's their solution, and we're able to put that change in effect a lot faster, a lot easier, and a lot more buy-in to that process. So you'll be hearing more about that in the next few months, what they're doing, how they're doing, and where we're going with that program of high performance. On the service side, the Finance Committee has already approved us going with an outside vendor, Airmark, and looking at helping us with the maintenance area and the housekeeping area. We have both of those department managers. Dempsey will be resigning, and his last day is next Friday. And the housekeeping, Estelle, retired about 2 months ago. So we got 2 openings there, and so we need to look at how we can improve, especially in preventing maintenance and some other areas where we're not doing a good job, and how we can increase that activity. And so Jess has done a good job of identifying a service that could help us map out exactly what we need to be doing and how we can increase the service. Jess put together some goals on them meeting HCAHPS, and it's a financial goal that if they exceed them, then they'll get a payment, but if they don't exceed them, then they'll pay us. And so you've got about 6 of those goals.
7. Maybe 7 goals.
Well, the goals are all related to quality and performance. As Bob mentioned, HCAPS, on the quality side, housekeeping has a goal there. On the budget side, both departments, there's goals that they state within budget. There are, on the maintenance side, in the environment, there's goals that relate to preventative maintenance issues and work order completion, timely basis types issues. These goals are all related to areas where we feel we need improvement. If they succeed 100%, they'll get extra money on each one of those goals. Or if they, kind of an interim payment to them also, if they succeed partially. Likewise, if it goes the other way, where payment to us, if they don't succeed on any of the goals, we get 100% of that incentive. If they succeed on partial, then we get some of the money back. So it's a risk-reward program for them that can cost them about $35,000 if they don't maintain those levels of 100% satisfaction.
Who are we talking about?
I'm talking about Aramark. Aramark is the national company that manages these type of departments for hospitals and hotels. They do a lot of hotel management in the state. They do some hospital management.
Used to be, they merged with Marriott and Service Master.
Service management.
Yeah, those two.
So you're talking about taking our homegrown folks out of the system?
The homegrown folks will stay as employees as they are now. They're bringing in a manager, an Aramark manager, to oversee those two departments, who reports to Aramark and to us on a daily and quarterly basis.
Because one of the strengths of the hospital has always been housekeeping.
Yes.
For, you know.
And we hope to improve on that. That's the whole goal that we have in mind, to increase the housekeeping cleanliness and quality of the way our facility looks. And the way the maintenance is done on things, the way preventative maintenance is upheld, and work orders within the internal system, the work orders that the departments submit get completed on a timely basis, and et cetera, et cetera. So it's a good program, and they have a lot of national resources they can draw on to their markets.
Sounds like we're taking the dollar out of somebody's pocket and putting it someplace else.
I think all the employees that we have employed now will remain the same. Remain as employees of the hospital. The salaries and stuff will remain the same. It's just that we're replacing the two managers.
And didn't you open up that, at least Dempsey's position for local people? There was nobody that actually had any hospital experience or that wanted the job?
Oh, Dempsey didn't have any hospital experience either.
I know.
And, you know, sometimes it's better to grow your own than it is to bring something from the outside. I'm not too enthused about that.
Would this be an ongoing
It's a
program?
3-year contract.
3-year contract? Just for everybody's information, what it is. Yeah, I've had them before, I think Jeff had them, QHR, several hospitals had them, and they, for us, they did a fantastic job. What do you know about them, Tom?
Well, I mean, they have a national reputation and they can bring some resources to improve. What I've seen happen oftentimes is that you grow better systems using them for a while and then go back where you do it all internally.
Yeah, so that's my concern, is going back.
I mean, you have the ability to do that, particularly if you grow good people within your organization and give them better skills, then you may or may not continue that relationship long term.
The other item on the report is we purchased a portable x-ray machine. And our x-ray machine went down, it was dated, and so it was stopping every 10 feet when you try to go to the emergency room or ICU for patients. And that doesn't work, so we decided to, go ahead and purchase that. It's a heavy sucker, so when that stops, it stops. And so we had enough money in our capital budget to cover that x-ray machine. And so the delivery date should be next month, May 2028. And this x-ray machine is digital. It'll go right into our computer system that we have now. And it's all digital, there's no hard films anymore. And it goes into what we call a NovaRad system. That's the system that keeps all of the x-ray images in digital. And we'll be looking at the Performance Improvement Committee, a little bit of change in the process of how we identify problem areas and how we can put what's called the lean process. That's the process of reviewing any kind of area for quality improvement, cost improvement, any kind of improvement. And it gives you, the whole theory is you look at it from a patient's viewpoint, and instead of us, with all of our years of experience, we do things because we've done them so long, and sometimes we don't stop and think, why do we do them this way? What is benefited by doing it that way? Where this system makes you look at all of that individual stuff. And so we're going to be putting that into the Performance Improvement Committee. And then on looking at our QHR consulting, we had Charge Master review probably about 4 or 5 months ago, and we've been going through that on a monthly basis, the action plan, and updating on all that information we have, and making sure Charge Master meets our needs and meets all the regulatory needs. And so that project has been 90% complete. So it's going well. The wage and hour review has been completed. Sheila will give you more of that in the executive session of what the salary review, what we found out in that process, looking at some possible changes. And then the case management review was on site about a month and a half, 2 months ago. And so they have reorganized their utilization review committee and are in the process of starting to work through that action plan on how to improve the case management whole process. Then the strategic business plan, that was mailed out to you. If that's the report that's 20-some pages long, so I won't go over it. But it includes all of the pillars and all of the goals, strategic goals for this year. So when you have time, you might review that. And we've given you an update for each of the goals, where they are. And so you spend time looking at that. Some of the kind of key points, again, is the PI committee, the Performance Improvement Committee on the lean. Also in the growth goals, our CT scan has increased 26% over last year, and our MRI growth increased right around 5% over last year. And the people goal that we recruited a PA and an OBGYN, which both started in January of this year, and all the managers did a good job of keeping the turnover rate down to 13.6 from 18 from the last year. And our employee satisfaction surveys improved from 70% to 80%. And the services working hard on testing to meaningful use. Meaningful use means that's the program that the federal government wrote up regulations for us to look at electronic records. And this is one of the first times that they actually put money with the program that they suggested. And so this meaningful use is a way to get reimbursement back from the government for us installing the electronic health record. And there's, how many phases? 3?
Maybe 4, but there are 3.
So we already met 1, now we're looking at how we can be meaningful use 2. we got back from one, the total amount of,
A little over 300,000 with another 200,000 expected.
that doesn't quite pay for it, but at least gives us some money. And that's all I got. That's enough.
Can I go back to the Airmark? I was asking Jeff what kind of cost that would be per year. Can you tell us that?
Our net cost will depend on whether or not the goals are met by them. And if they meet all those goals, and those criteria, HCAPs and PMs and all that stuff, we'll be paying out annually about $44,000. If they don't meet any of those goals, we pay out annually just over $9,000. I don't suspect that they will meet all the goals right out of the chute the first year. I suspect we'll be paying less than the $44,000. They're gonna try very hard to meet as many as they can over that 3-year period so they can get up to that highest level. But somewhere between $9,000 and $44,000 will be our cost.
And I don't know what the salaries are of Dempsey and Estella, but it looks like we're right in that figure. Yeah, so, and I agree with Dr. Gutierrez, I'd like to, down the road, see that we put somebody of our own to run those departments, if that makes any sense.
Yeah, we've been taking interviews ever since I got here.
And we knew Dempsey was going to be leaving for quite some time.
Yeah.
So, it's not like we didn't try to find some people to take over these things.
Well, this might be a good opportunity for some local people to get some training that to step into those positions, because you can't get somebody off the street and do it.
Right.
And that's what I like about it.
There's so many,
3 years is not forever.
Right, it's a very short period of time.
there's so many rules and regulations that we have to abide by architecturally, and designing ability to be up to date. The Joint Commission safety rules and regulations, and the state, rules and regulations. So there's a lot more than just fixing the gateway here. There's a lot more involved in management of that.
And that's why I brought it back, so we can get a little more information.
If I hired 2 people, cost more than $44,000, wouldn't it?
That's part of it. It's in the cost. One manager, one secretary.
That one manager would do both housekeeping and.
They usually look at also food service, but we decided our food service, we can't improve on what we got. So, you should
And
look at it.
in reality, I don't think you can improve in your housekeeping department either.
Yeah.
They've been so strong for the 2 disasters that we've had in this hospital where we've actually mobilized for disasters. The ones that saved our butts were housekeeping. They were the ones that stepped up and did off-the-street nursing and taking care of patients. That housekeeping was strong. And we have no issues with it, as a rule, with the cleanliness of the facility. There's some manager people that have been stronger than what we've had, but they've changed. They're pretty strong department.
I have a question on the business plan.
Sure.
My copy that I received didn't have the update, the progress report figures filled in towards the end of the report. Do those, who was supposed to do that? That was emailed to us.
Yep.
They're all blanks. I mean, you can extrapolate it from the report, I guess, but usually they fill out, we should have first 2 quarters done by now.
Okay. We'll get those figured out. They're not filled out.
They're not filled out, but the one I got, I presume that was everybody's.
Okay, thank you. Mr. CMO, report?
As I told you before, we have to review the bylaws and the rules and regs of the medical staff every so often, and they have to be approved by the board. So hopefully in the next, I don't think we'll have them ready for the May, but because the medical staff has to kind of go over any possible changes, and then bring it to the board, because the board has the final authority to review it. Okay, and then, the recruiting, Bob took everything out of my report, and yours, I mean, he just takes it all, but on the recruiting, we do have, what we're getting more from New Mexico Health Resources, which is a company here in New Mexico that sends us doctors' names that we don't have to pay for that recruiting, and that's a wonderful thing. And we've actually gotten some mid-levels and names of other people, nurses and so forth. And there's a doctor that PMS, and we are kind of jointly recruiting for 2015, who's family practice, who does OB, who wants to do the full range of everything. He sounds really excited. And he's coming next month to visit, to do a rotation at Zuni. Then we're going to talk to him and see if we can, he's being kind of heavily recruited all over the state, that he'd like to be in New Mexico. So we are trying to all talk to him at the same time. There are some other possibilities, like Bob has already mentioned. We're also working on some policies, some administration policies that need to be reviewed and reorganized, and we'll do those through administration and medical staff. Credentialing, we have the ongoing credentialing that we've talked about before, the OPPE, which is ongoing practice evaluation that we have to do with all of the physicians, and that information is kind of what Annie was talking about with coding and with hospitalizations, with insurance, with length of stay, all of that. We used to get that information in an organized way through press gaming. I don't know if I've mentioned Crimson because it's fairly new here at the board, but we have a new company that we've contracted with that's a nationally known company that we go through the same kind of information. We have to upload it, but then they give it back to us so that we can have that in the reports. It's the kind of things that people can go online now and check out, and we have to have those in our reports. And it's all part of the credentialing process and being sure that we're trying to get the most accurate information. Also with I was in the PIC meeting report, I was going to talk about Lean, but once again, Bob has talked about that. And the Lean process, we'll probably be having some board education on that, because it really is, I think we should have a different name like I said before, but it's a whole process that started with the auto industry and became part of all the companies, a lot of companies, and healthcare in particular, to get rid of waste and to do everything as effectively as possible. We talked about that in PIC. And to have every step count. And so we're really getting excited about this, and I think it's going to take a while, but we'll be starting with the different groups and departments and try to find out how we can most efficiently take care of patients, because the bottom line is taking care of our patients safely and efficiently and effectively. So we'll talk about that a little bit more in the PIC. And that's it for me.
Okay, questions for Dr. Shipley? Okay, we'll go to the CNO report.
We had some good news and celebration this month. We're part of the HIN. HIN is the Hospital Engagement Network. And we got some kind of incentive, that's a good word for it, everyone else to call it. They sent us some money. So that's incentive to us. And what HIN is, it is the New Mexico Partners for Healthcare and Safety, and we elect to be part of it. And Cibola is one of 4 critical access hospitals that participate with the partnership with the New Mexico HIN. It is the top performer of New Mexico HIN and active in all the topics. There's several categories, there's 10 of them, And lots of places just choose to participate in 4 or 6. We participate in 10, and in all topics, we're consistently in the top 25% of the New Mexico hen. So it was a good celebration, so we bought pizza. What else do you do when you celebrate for our staff? Because there's a reason we got this award, and we did it for day shift and night shift. But we're very appreciative of the work. Some of the topics that we follow are like adverse drug events, CAUTI and CLABSI, that has to do with Foley, urinary tract type infections, falls, early elective deliveries, OB adverse events, pressure ulcers, readmissions, surgical site infections, ventilator-associated events such as pneumonia, and also VTs, venous thrombosis, embolism. Okay? So there's a lot of stuff we follow and a lot of data to ensure that quality is being provided. So that was a celebration. Our next one was that we have confirmed as of today, actually, our 3rd permanent nurse for OB. If you guys have been on the board or for a while, you'll know that we've had contracts on OB and it's been killing us. And we've been working real hard to get some nurses in for that position. One's a Filipino, 2 are from nearby. Both are from Texas, aren't they? Both are from Texas, and then we're going to be training one of our ICU nurses to an OB position. So there's some movement and training to be had, but we hope one day we'll be able to report to you that we're contract-free on OB. We are presently looking for an OR director. We've interviewed 1. Interviewed 1.5, and we have another phone interview. When Glenn and I whittle it down to a couple of candidates, we'll present it to the executive team and to the physicians and to our staff to help us choose the right person. We still have a OR contract that we need to fill. We need a regular staff for that.
Would you explain the difference between contract and regular for people that might, people that might not?
A contract nurse is somebody that comes on an assignment that usually is a 13-week assignment, and their wages are quite a bit higher than almost double what our regular staff is. And so they really can hurt you, financially. The other, even more important is, they're not vested in your hospital. They don't know your routines and your initiatives and this and that does affect, what you're trying to achieve as a group, as an organization. So it really is nice to have your own permanent staff, your homegrown staff, so that's what we're really shooting for.
Homegrown Texas.
Homegrown. Well, we've been working on the contract for OB for forever, for as long as, Glenn and I did a night shift call for years in our younger days. So, yeah, we've been working on that a long time.
And these contracting individuals we're talking specialists, right?
Well, when they come to our facility, when we interview them to tell them that, yes, they do have that labor and delivery specialty, but they need to be able to float to other areas, because in our small hospital, we need, if there's no OBs, we don't want to pay them for nothing, so we have them float to other areas to help us. So when we interview contract nurses, we're very specific about our needs, because, we have to spend our money wisely. I told you about that. We just completed, Glenn and I do education. We just completed a PALS course certifying 12 RNs in that, and so we're always happy. Excuse me, Pediatric Advanced Cardiac Life Support. Every month we offer education for our staff and certs that's, of some sort. Next month in May is our big clinical carnival. It's a 2-day event where we enlisted a lot of our supervisors, a lot of help. And what we do is every one of our nursing staff has to go through it. They're 4-hour shifts. It's 2 long days. We get outside vendors and stuff, and they go through the carnival and knock out their competencies for the year. We have certain requirements by TJC that we must meet, and the other topics we muddle over and plan a lot to choose topics that are high risk, or that mean, you want to make sure you're up to date with it. You just don't see it that often, and we make sure we hit those kinds of competencies. So we try to make it fun. We let the nurses choose the theme, we go with the theme. You know, remember they chose Disney this year. Last year it was zombies, so Disney's. So they choose a theme and then we try to go with that to make it fun, but also get what we need done. And that will occur during nurses' weeks and hospital week. So we're going to incorporate a lot of things that we get to be able to do. Like I saw in the report, Glenn and I saw the HCAPs are down still. And so, you know, we enlisted help from our coach because we can't figure out what the heck happened, why it's different. We've gone back to some basics with our staff because realizing we do have young nurses who are staff and maybe they didn't quite get that initiative and understand everything that we're teaching. We just got through staff meetings. We do 4 staff meetings a month and all of our staff, we have staff of 70, about with our PRN and part-timers, and just went over some of our initiatives. The little pamphlet you have is one that was developed for staff meeting. On the front, you'll see it has AIDA, and that's just one of the communications that our hospital-wide organization has adopted. The other is examples of keywords and key times. These are just initiatives we have. And then on the back side, it has a 5-10 rule. You can take it home and look at it, and if you have any questions, you can let us know. And the last thing, well, I guess that was the last thing, huh? You guys have any questions for us?
Okay, thank you. QHR?
Bob's already covered the consulting part. Sound like Dr. Shipley here. Really just a couple of things. The QHR newsletters, I'm not going to go through those. I was going to try to focus a little time on ICD-10, but I think Annie gave you everything you need to do. I think it's more important about what's going on specifically here, and you got to hear that tonight. For those of you, the trustees that are going to the trustee education in Denver next week, I'll be getting in touch with you. Hopefully you will be there in time for dinner on Wednesday night. I'm going to host you along with the trustees that will be there from Taos for dinner on Wednesday night, and then everything else is pretty much planned for you, for the keeping you busy for the all-day Thursday until Friday noon when the meeting is over. But most importantly, I wanted to give you an update on the permanent CEO search. Just as a reminder, you remember Angela Cobb, the recruiter, was out 2 or 3 months ago and developed a profile, and she has finished her screening, and the candidates that met the criteria all came to me. I have interviewed all of them now by telephone, and am in the process of doing the face-to-face interviews before I narrow it down to the finalist candidates to bring in to interview here. I'm down to 6 candidates, which I'm glad I have that many. That's good. And I still have 3 to meet face-to-face. One I met today already here, and then tomorrow I have an interview in Albuquerque. And so then I have 2 additional that I need to schedule the time to come. So I hope to bring candidates in to the board, and I'll be working with you, Ron, and Jenny to try to get this all scheduled. But as a reminder, what we hope to do, if it works for your schedules, is to try to do this in as much of a compact time frame as possible. I don't want to have somebody come in 1 week and the next week and the next week, and then it's hard to compare the 3 people or 4 people if it's spread over a long period of time. So we'll try to compact them all in a very short time frame if possible. And I'll be working with you guys to try to schedule the times. I'm hoping to get candidates in for interviews in late May or early June, depending on whether I can get these candidates in for face-to-face interviews. And when I say face-to-face, I don't want to bring anybody in I haven't met. And in this particular case, all the finalist candidates that I have at this point are people who have not worked with QHR before, or I have not worked with before, so I need to not only do all the checking and the references and the background stuff, but I need to see them as well as do telephone interviews. So trying to complete that process takes a little bit longer. Just as a reminder, when we do schedule these, we want the candidates to interview with medical staff leadership Maybe even an opportunity, I think we've done in the past, like a luncheon drop-in, so any physician on medical staff has an opportunity to at least meet them and provide feedback. Senior management team, meet with the department managers as a group, and then obviously the board. And the board makes the final selection. It's your decision who your CEO is. I think I mentioned when we were talking earlier, it hasn't happened. It's only happened to me once in 22 years. But if for some reason the candidates come in and you don't want, one of those candidates, then we need to go back to the drawing board. I think the important thing is to get the right candidate, not only who has the skills, but who's a good fit for the hospital, who's a good fit for the community. So that's the goal here. So if it takes a little longer to get done, that's what we need to do, rather than just get somebody in.
Any questions for Tom? Okay.
Glenn and Maria have to like them. It's a waste of time.
That's right.
Dr. Ship?
The PIC, or Performance Improvement Committee, Quality Committee, is all about trying to find ways to improve the quality of care in the hospital. As most of you know, we've talked about this before, but for the new people, we have a couple of board members. It's a combination committee with the board, the medical staff, and other staff, so that we can all get together. And it's in a position of flux. We're changing things around because this is the committee that's going to be the source of the Lean project and the focus on improvement in the different departments and hospital-wide. So we did have a couple of reports that were given by the obstetrics department and emergency department, and there are some good things going on, their own individual projects that they've been watching to see if they, for example, in OB, they're monitoring whether they're consistent with an ACOG, American College of Obstetrics and Gynecology rule, and they have been right up there 100% basically. ER is working very, very hard on really starting the projects on patient waiting time and patient, because that's always an issue. I don't know if you saw that thing, I don't think it's doing that on how long you've been with or anything. But we do a pretty good job in general, and they're really starting to do some patient satisfaction issues to try to get those scores up. And then again, we talked about, Bob and I talked about Lean and how that project's going to work. It's a whole process by which we identify an issue that we may want to improve on, and then after we've identified it, it's a kind of neat process to go through each of the steps to see where we can cut out any waste, or we can improve the quality and improve the patient care. So I think it's kind of exciting. We'll have a lot more reports on that as we start progressing through that. And that should be enough. Any questions? You can ask Bob.
Thank you, Dr. Ship. Finance Committee report?
Yes, we have today. There was a approval of the amended agenda, approve the consent agenda, and reviewed the QHR invoice review, and it was pretty well on. The contract log review, we reviewed the contracts coming up, and we also we had the error mark proposal, we agreed to go along with that. He had sent us information on email, and I think that was in conversation. So that was probably the best thing to do. Of course, we have the finance report. We have the update on the Soul Community Provider Funds, which didn't look too good. We're doing the best we can with it. So, I don't know if you want to mention what you mentioned to us about that. It's tentative at this point, but it looks like for next year, starting July 1st through June of 15, If the numbers shake out the way they look today from the state and Hospital Association, then we're going to get about $2.1 million net from the program, as opposed to the year before last, we got over $6 million. So we're a 2/3 cut, roughly speaking, compared to what we're used to getting. So that's another reason for our lean project, to be more effective and efficient with what resources we have. The last 6 months of this year, through June 30th, we still do not have any final numbers of what we're going to receive from the program. We haven't ingested well over $1 million, not close to $2 million to the state so far for the December 31st through June 30th return of monies, and we don't know what that's going to be yet. If we're going to get that all back, we don't know. So we'll get a little more for the rest of this year. We received $3.2 million so far this year through December, and we don't know what we're going to get second half of the year. So the program is being reduced with the advice of the federal government and the administration of the State Department of Health. All hospitals, all 26 or 29 hospitals in the state that have been getting that funding are feeling the pinch. Some more than others. We're probably one of the more fortunate ones financially. We have a couple of hospitals in our state, one particularly close by that has no cash and needs that cash to operate, and we're really struggling to keep the doors open right now. So it's going to have a big effect on the state. But looks like we're going to get about 1/3 of what we've got in previous years.
Any questions on that? Anyway, we also brought to attention that our capital outlays, there was $450,000 was set to, for removing digital X-ray for moving to next year. And we approved a $11,245 for our incubator for the lab that was not budgeted for. We approved that. And then he gave us 2 full sheets of budget assumptions for next year. If anybody wants to discuss them with him, we're ready and available.
I might add on, like the rest a little bit on the capital expenditures. We're also going to add in a wireless system for patients. So we've had a lot of people complaining, patients and families, about they can't get onto the internet while they're here. And their patients, they bring the laptop with them, and they're used to accessing the different sites. So we're going to put some money into that, about $5,500 to set up a major network for our people. We'll get password and stuff, and it's not so good to anybody, but we're going to implement that in the next probably 2 months. That will help with our patient satisfaction scores.
The next item, we explained the employee incentive program that proposing. I think it sounded like it was be very cost effective.
As we move forward, we're trying to be more lean, I guess, and so we're more efficient with our resources. One of the ways that we can possibly do that is by getting our employees involved in trying to reduce expenses in certain areas. Plans that we've seen successfully in the past are employee incentive plans that allow them to provide information on how to save money for the hospital, for their department, for a certain whatever. You set the criteria up, and then they get a portion of those savings. You set that up over every quarter, the executive council will evaluate applications and give first, second, and third prize if we've received applications. And then at the end of the year, we'll give a kind of a grand prize at the Christmas party, employee Christmas party, with the best suggestion for the year. And then if somebody comes up with an unbelievably good idea that saves the hospital a lot of money, a whole lot of money, like $20,000, $100,000, we will give them a 20% share of those incentives. It's not up front, we're not gonna give them the money up front, and we're gonna go through a lot of criteria to verify that that is a potential savings, say, over an annual period. If we do that in finance and we come up with justifiable numbers, then if the executive council approves, then we would give them half of that 20% after it's verified, and then you go through a whole year of testing to see how much you really did save. And after that year, you verify the numbers again, and then you give them the second half or whatever 20% of the whole thing is. So the employee can generate a lot of funds if they come up with a big idea, or they can get a couple $100 here and there too to help out. So it's something that we're going to try. It's a program that usually has a short life to it as far as number of years. It's usually a 1 or 2 year program. Ideas running out pretty quickly, but it's worth a try. Trying to save 10,000 a year or 10,000 there. So we'll see what kind of participation we get from the staff. They're the ones in the trenches. They know where some of the waste is and possibly where some of the savings are. So we'll see what happens.
The executive team or the department managers are going to be eligible for this incentive program. That's their job. You're looking at cost. But then the employees, if they come up with a good idea, that's the ones that, and physicians can't qualify either.
We're just gonna throw Mr. Hernandez out in the parking lot.
Inside joke.
Yes, it is.
We also have the, Orchard back here.
Let me give you a little, you do have that draft background, if you expand on that a little bit for you, what's going on in March and year to date. You can see our graphs all look pretty good. I'll go through some financial information. In the month of March, our overall revenues were up about 4%. That was mostly the outpatient arena. Inpatient was down about 5%, outpatient was up about 9%. Our contractual allowances or revenue deductions that we write off for Medicare, Medicaid, and others, those were up 2%. Most of that increase was due to Medicaid. Our operating expenses were pretty stable, pretty much on budget. And then our excess revenue was up due to the increased revenue and usual expenses. Year to date, our total revenue year to date compared to budget was up about 2%. And most of that's in the outpatient arena, that's 4%. Our other revenue, which we've been very fortunate in the sole community provider funds, our other revenue is up 1/3 over what we budgeted. Keep in mind, I mentioned earlier that we've received through December $3.2 million, which is what we had budgeted for the whole year. We know that we're not getting much more than that the second half of this year, but that has put us over budget-wise. So if we get another $1 million or $2 million above that $3.2 million, we'll be that much higher than our budget. Also remembering that what I told you about next year is down to $2.1 million, so it's going to drop off quickly. But this year, sole community-wise, we're going to be okay. And the goal of the board is to have a net operating income break even without sole community and build up. We're there right now. Okay? We need to maintain that over the next several years. Contractual balances for the first 9 months of the year are down about 1%. Operating expenses are about even with the increased revenues. And excess revenue is up as you can see. So we're still having a good year, even with the potential reduction in sole community. So
Any questions for Jeff or Paul?
County indigent funds paying off any?
we don't get any direct injury funds. We get just sole community provider funds.
But that doesn't count for those who, is that, the county indigent funds are separate from that, aren't
Yes. You get no distribution from the county.
they? I was just asking to start distributing.
Any other questions, thoughts?
The
Approval for the finance committee report. Paul makes a motion. Second by Carlos, all in favor? Aye. All right, okay. Need to go into executive session, motion there.